conversation that Dr. Redfield and I had. A year ago, as we heard the rumor that President Trump was about to appoint Dr. Redfield as the director of the CDC, I got a phone call. And you all know that this is a bipartisan issue, so I was surprised when the phone call came from a colleague of mine from the red side of the aisle, who I hadn't heard from in a while. And he said, "Jesse, it's very likely that Dr. Redfield's about to be appointed head of the CDC. Will you talk to him?" So I did. We had a private conversation with just 3 of his aides listening, and I was told I could ask him anything and say anything I wanted to him. And I did. And on your behalf, knowing that as a person of faith, and so is he, I could at least pull that card, I said to Dr. Redfield, as a Republican and as a Catholic, where do you stand on prevention for gay and bisexual men? Where do you stand today on needle exchange? Where do you stand today on the transgender community? All right. Dr. Redfield led with, "I'm a scientist" card, and I embrace all scientific methods of prevention. But then he surprised even me by saying this, "But Jesse, I'm a father. And I believe in health equity for everyone. And yes, that includes gay men, women, and men of all colors, needle exchange, and the trans community." Couldn't believe my ears, so I decided to bring some of my peeps in to hear him say it himself. So I brought in the executive director of INMAC, the executive director of NASDAQ, and the executive director of the National Coalition of STD Directors and the ED of the AIDS Institute. And I said, "You get your chance to ask Dr. Redfield a question and to hear him say it himself." And he did. And 2 hours later, the New York Times called me. The New York Times called me and said, "We heard you talk to Dr. Redfield. What did he say?" And I said to the New York Times, I heard him commit to health equity for all of us, commit to needle exchange and to the trans community. And I said this to the New York Times, and we will hold him to it. The day after the State of the Union, I was called with those other 4 EDs to a meeting to find out who was in charge of this new initiative. And we walked in the door, and there was Dr. Redfield, one of the 5 architects of this new national plan. And Dr. Redfield said this to me: "Will you all take a risk on us?" I'm a poker player, so I said, "I can best him." I said, "Will you take a risk and come to AIDSWatch?" Well, here he is. And he will answer any of our questions that we have amalgamated from all of you. But first, Dr. Redfield, the nation's best advocates, welcome to AIDSWatch.
Well, I want to thank Jesse for that kind introduction. We actually have been brothers in the fight bringing in the HIV epidemic for a long time, and I really do appreciate the opportunity to talk to you here today. If I can get my slides up. Right. I don't want you to get you nervous that I'm technically handicapped. Great. It's an important theme that I want to highlight the idea of seeing the possible.
That's right.
And leading. And you all are leaders, leading our nation, our community to act. And I do want to echo what Jesse said, and I did say that I understand there's a great deal of skepticism, and it's grounded in a lot of reasoning. But I really do hope that the community here at AIDSWatch has the courage that we've shown over the decades of confronting HIV, the courage to help us all realize what I do think is no longer aspirational, but is a concrete, real reality that we can bring an end to the AIDS epidemic in the near future in the United States, and we continue to work to do that beyond. You know, for far too long, those of you who know me know that I came out of my training in infectious disease in 1982, and I had decided not to go into oncology because I had difficulty with the reality of being a good doctor with patients that just seem to die. Many of you know my first son died, and God has a funny way of teaching you how to see the other side of medicine. I saw medicine through the eyes of a father who lost his son with my wife, and how impersonal the medical community was at that time. And then lo and behold, I end up being asked to start looking at this new disease, AIDS. And it only took me a short time to start meeting the men and women with HIV infection that I got to care for, privileged to serve, that many of them became my friends, and now fast forward from 1983 to today, it's been the focus of my professional life. But the reality is we've lost too much. Many of you have lost friends, I've lost friends, loved ones, spouses, children. And over 700,000 people in our country have died from AIDS. And if we don't do anything, we just do the status quo where we are now, another 400,000 people are going to confront and live with HIV infection, all in a better circumstance than the original men and women that came before them, but still a significant number of people if we just continue the status quo. And we made a lot of progress. I can remember the early 90s, as Jesse and many of you can. I can remember, you know, at the peak, about 130,000 new infections a day. I mean, a year. 130,000 new infections in a year. Significant new infections. And then we made a lot of progress, and you can see we got down to around 40,000. But really for the last 5-6 years, we've been stagnant around 40,000 new infections. And if we, as I said, if we do nothing, we can anticipate another 400,000 infections between 2020 and 2030. If you look at the epidemic, and I know you all know this, but it's really important, I think, to understand it is disproportional into the South. It's a reality. It is disproportional in the African American community. It's increasing in Native Americans and Alaska Natives. And 70% of today's new infections are occurring in men who are sexually. If you look at it, it's not only that, it's actually young people. The epidemic largely disproportionately in individuals under the age of 35, both African American and Latino men who have sex with men, as you can see here. And even more disappointingly, although we see and we think we're making progress, as you can see, if you look across this slide, in some groups we're really making progress. But if you look at the group 25 to 34, African American men who have sex with men or Latino men, that epidemic has actually increased by almost 65%, 68%, at a time when we feel that we're making a lot of progress. So this is a very demographically epidemic right now, where individuals are being left out. They're left out of benefiting from the tools that we have to bring an end to this epidemic. And again, that's going to be one of the challenges, and one of the challenges that I'm going to ask you all to help, if you have the courage to put your skepticism and hold on to it, but are willing to work with us to bring an end to this outbreak. When we originally did this, I asked the CDC to map the 40,000 infections that are across the United States, not in a typical CDC way, which is to do it per 100,000, and if you did that, the map just looks like a blur. I said, I want you to map each individual person that became HIV infected in 2016 and 17 as an individual. Map them as an individual and show me where that epidemic is that we're missing. Who's falling out of gaps? And you can see when we did that, it came out that 48 counties, Washington, D.C. and San Juan, represented over half of all the new infections in America. Now remember, we have over 3,000 counties in America. Half of the infections were only in 50 jurisdictions. And I can tell you, when this map was showed to non-medical policymakers, they said, you know, that concept that you and others, Tony Fauci, George Lunas, the head of the Indian Health Service, and Admiral Giroir, you know, this is not just aspirational. Actually, this can be done. And then the question came, if it can be done, let's develop a plan to do it and to get on with it. Well, one thing we realized right away about those 50 jurisdictions is they were all urban jurisdictions. And many of you probably in this room know that HIV infection in the rural South, particularly in rural southern states, is complex in and of itself. And if we developed a program that did really well in the urbans but ignored the challenges of confronting stigma in the rural South for transgender persons, for men having sex with men, the complexity of HIV in small communities, in tribal nations, that we really wouldn't have accomplished our goals. And so we looked to see what were the most highest states that had infection rates, but were rural. And we found 7 states, and you can see them highlighted there in blue. And we said that we simultaneously need to target those states and work with the community, you know, in the community, for the community, and by the community, to figure out strategies that are going to work to meet the needs of the men and women that are living with HIV infection, the men and women of transgender persons that are at risk for HIV infection, and be able to develop programs to actually meet our goals, which was to eliminate the HIV epidemic in America once and for all. And so that really was our goal, to reduce new infections by 75% in 5 years, 90% in 10 years. And when I say in the epidemic, it's sort of a technical term. Those of us define if we can bring HIV infection rates down below 1 in 100,000, that, quote, the epidemic will now finally be over that began in 1981. Obviously, we want to go lower, but that is sort of the scientific definition of ending the epidemic, less than 1 per 1,000, less than 300,000 cases. I mean, less than 3,000 cases in the United States per year. And the first phase was to focus on those focus areas that we talked about in a very, very targeted way, and then to expand beyond that and eventually get to phase 3, which is to really get to the phase that we can truly say that the HIV epidemic as an epidemic has come to an end in our nation. And we're going to do this really by, most importantly, applying the tools we have. Many people have heard me before say that science on the shelf has no value. Has no value. And if you look back, just some great examples of it. 1929, Fleming developed a drug called penicillin. He didn't really know what he had. And it literally sat on the shelf until the early 40s when it was rediscovered to have value and it could save lives. The truth is, we leave science on the shelf all the time. And part of this is to take the tools that we have today, as you all know so well, the tools of diagnosis and treatment, comprehensive prevention, which Jesse talked about, and to be able to allow those tools to be applied, not to some people, not to those who have easy access, but actually to all people that are living with HIV infection, to all people who are at risk for HIV infection. And I do believe, as Jesse alluded to, that we could set an example of how to provide health care for those who need it for the different diseases they have. he knows I do believe in God, and he did mention that I am Catholic. And I do believe that health and equity be one of the greatest social injustices that our nation has around the world. So this is what we're going to do. Diagnose, treat, protect by providing comprehensive prevention to men and women, transgender persons that are at risk for HIV infection. Respond to new cluster outbreaks. Clearly it's gotten a little more complicated in 2019 than it was in 2000, say, in 2000 because of the co-occurring opioid and drug overdose epidemic that we're having. And to really build a workforce. And I will tell you that a large part of that workforce we need to bring this to the end is the community. People like you sitting in this room to get engaged in your communities in an effective way to help us work together to bring an end to this epidemic. And diagnosis, it really is very disappointing to me as someone who's always embraced the importance of early diagnosis of HIV infection. You know, it's a critical tool that we have, needs to be utilized. Who would believe that as we sit here today, that 50% of the people that are diagnosed actually have been infected for at least 3 years, or 25% for 7 years, or we're still having, 1 in 5% with advanced disease, or 7 out of 10 people diagnosed last year actually had seen a healthcare professional in the previous year, but they just weren't diagnosed. We need to get HIV diagnosis there, and we do need to challenge and get help from the innovation community like yourselves, because I've always said that maybe we ought to learn that building a health system that says we'll take care of you provided you come where we are may not work as well as we try to start developing one that gets a health system to go where the patients that need it are. 80% of the new infections that we see, we can attribute to individuals that either have been denied an early diagnosis or were diagnosed, but they weren't effectively linked in maintaining care. And if we could just do those two things, we could really confront over 80% of the infections that we're trying to prevent. And so CDC is going to work to do that. I'm going to come back to you all. The last bullet on here is to figure out how to develop better non-clinical access to diagnosis. If we continue to do everything exactly the way we've done it for the last 35 years, we're probably going to end up with the same result. Secondly is treatment. And I want to take a stop. Jesse mentioned, a lot of us, it was tough when I was first a doctor taking care of HIV patients or AIDS patients in 83, 84, 85. Many of the individuals I was privileged to serve died way before they should have. I still remember the last woman that was just 4 weeks, died 4 weeks too early before the protease inhibitors could save her life. It did save her best friend's life, who's a dear friend of mine to this day. But I want to acknowledge first how we got there. And yes, a lot of science, a lot of federal investment, a lot of private sector. But the way we got there is the people that sat in these chairs before you had the courage to participate in clinical research. So the community, again, was the reason we got where we are in therapy. So as today, that basically you can pretty much predict to live close to a natural lifetime. If you're 20 years of age now and you get diagnosed, you can anticipate to live somewhere between 72 and 75 years of age. So that's an amazing accomplishment. I don't want you to underscore the credit that you need to give to the men and women that had the courage to participate in the clinical research and brought that to a reality. Because without that, it would have never happened. The second thing that we need to do is we need to link people into care. This is not a sophisticated medical requirement. And if you look at the health systems of America, the one thing we've continued to fail to invest in, whether it's in dealing with hypertension, diabetes, or addiction, or mental health issues, we haven't invested in this comprehensive requirement to provide a healthcare system that meets the needs of the individuals where they are. And I think this is, again, something that we're going to need a lot of help to effectively engage and re-engage. We're not trying to engage people now in care that are simple. We've already gotten that done. We're trying now to engage people in care that for whatever reason have been difficult to effectively engage in care. And again, I'm going to come back to the statement, if we do exactly the stuff we've done in the past, we're going to end up with the same result. And I'm looking for the commitment and innovation of people like yourselves in this room to help figure out how to create those systems. I will say I had a great opportunity to be part of President Bush's PEPFAR program, and the programs that I ran eventually put over 700,000 people in Africa in care in very rural Africa. And I was saying we were able to eventually build health systems with very little health capacity to get people linked to care, keep them in care. Very proud of the fact that we had almost a 90% viral suppression rate and almost a 95% retention rate all through Africa. I think we can do that in Africa. I also want to highlight that it's important that we recognize that there are multiple different communities confronting HIV infection that have different complexities. This is just looking at viral suppression rates overall. The Ryan White program has close to 86% viral suppression rates, but you can see this is from New York State. There are populations, and it is worth a clap. I mean, I think the Ryan White program does a great thing. It's a great program. But you can see there are populations that are being left out to side. Transgender persons. I don't think we have care delivery systems that transgender persons find comfortable to go to. I think we need to create, we need to provide. I think we need to look at adolescents. We have adolescents. You see the young 13 to 19-year-old. We're not reaching them effectively. Even if we diagnose them and link them to care, they're not being effectively treated. We need to develop more innovative ways to accomplish that. And we're challenged the community to do that. And so we're going to continue to try to accomplish that working together. I mean, the game changer for me, I saw the advances in treatment, but the game changer for me was not the 1.2 million people that are HIV infected, for them to get into care and treatment. I thought we'd plot our way through there eventually. But how about the 1.2 million people in our nation that are at risk for HIV infection? How to get them to comprehensive care? And Jesse already said, you know, I'm an evidence-based, science-based, data-driven person, and the data's there. And the bottom line is that condoms and sex education do have an impact, right? They ought to be utilized. More importantly, syringe programs have an impact. They need to be utilized. But I can say this, and you'll hear my friend Admiral Gerard talk about this. He's much more articulate than I am on this issue. Safe syringe programs don't only prevent HIV infection. They don't only prevent hepatitis C infection. I don't know how many of you know that if you go into a safe syringe program, you know you're 5 times more likely to go in treatment for your addiction. 5 times. And if you do go into treatment for your addiction, you're 2 times more likely to have long-term success. So what more data do we need in the midst of an opioid drug overdose epidemic to make safe syringe programs available to people, and to see that not only are they going to help us in the AIDS epidemic, but they're going to help us in our response to the opioid and drug overdose epidemic. And finally, pre-exposure prophylaxis. I mean, we have a biological mechanism now to prevent HIV infection. And we really do need to see that all persons that are at risk for HIV infection can have access to comprehensive prevention services, including PrEP. This shows you a map of where the requirements are and sort of the states that are out of sync right now. You're going to see fundamental to this program is to move forward, again, developing innovative, non-clinical. I mean, the idea that the only way you can get PrEP now is to walk into an HIV clinic is probably not going to get 1.2 million people who need it. So we have to develop innovative, non-clinical programs to get PrEP to the individuals where they are, and we need to get to them as a community rather than the other way around. And you can see there has been progress. This is recently from the COIN meeting. The CDC said that the attitudes are changing about PrEP. It is expanding, but it's by no means where it needs to be. Okay, again, our goal in this program, and when people ask me, I say all people, and they say, well, what about these people? I say all people. And they say, well, what about these people? I say all people. All people at risk for HIV infection. And we're going to work together with you in the community to accomplish that. Finally, I want to talk about some of the challenges because of the co-occurring opioid and drug overdose epidemic. I mean, this is a real tragedy, as you know. Over 70,000 people died last year from drug overdose. Drug overdose and the co-occurrence of drug use has had the opportunity to cause a variety of different clusters. I know there's sensitivities about this. We can talk about the questions. This is not to be name-linked or anything. This is to give the public health community the opportunity when we see cluster outbreaks to be able to intervene with rapid deployment forces to basically go in and help the public health community get those outbreaks contained, get those people in care and treatment, get those individuals on comprehensive prep. The other thing I want to say is that, and so we're going to work to do that in ways that we can talk. The most important thing is we need to put a workforce together. And the most important part of that workforce is sitting in this room. It's the community. The community knows better how to reach the community than how to reach the community. But we can't do that unless the community will have the courage to maintain its skepticism, but be willing to work with us to get this done. Because it is the community, I think, that's going to be key to getting this done. And not just the community here. I told Jesse before that one of the key parts of the community that we need to build the trust with are the HIV persons that get infected in the first couple of years of this program. We need to get them to trust us to come in and teach us what didn't work. How did that happen? What are the gaps? And again, the community is going to be fundamental to being able to help effectively engage those individuals to realize that we really do honor them as teachers. We do want to learn from them.
We can help you.
You can help.
Yeah, please quit calling us infected.
Infected is a stigmatizing word.
What did you say?
Infected is a stigmatizing
You
word.
know, I learned that the other day.
You said it 100 times.
I know.
We are not infected.
I think you're right. I do think we have to understand the subtleties of the stigma. And I do appreciate that. And I think we need to constantly be reminded to learn it. I told you many times, I think people have heard me talk before, one of my sons almost died of a drug overdose, and I find the word addict very stigmatizing. And a young woman from Oklahoma the other day did say this to me, and I will continue to try to correct that these are people living with HIV. And I think that's
This was created by people.
Thank you so much. I agree with you, and I think it's, allow us that we're all in school, we're all trying to learn, and even those of us, and I think, as I said, obviously I'm not a quick learner. The other day, a young woman from Oklahoma made the same point to me, and I've obviously failed to totally embrace that, but I will continue to try to adopt it. And people living with HIV. And I think we can continue to do that and continue to do that, and you continue to correct us when those of us need to be corrected, and I appreciate it. The last thing I wanted to say before I close was that we don't have any pretense that this was a new idea. Many of you have worked with your jurisdictions to have programs. Many of you have had remarkable success. The New York program, the Washington, D.C. program, the Washington program, the San Francisco program have really shown the possible. When you see the District of Columbia has decreased new infections by over 50%, New York's jurisdictions by 25 to 30%, San Francisco substantially, Washington State. So I don't want you to preclude that we don't think, and we want to work with all the jurisdictions that have begun to learn how to get this accomplished. And finally, I sort of close, I don't know how many of you are of my age bracket, but I always, probably not too many, but I always remember when John Kennedy got up, and I was a big fan of President Kennedy's, got up and said that he was going to put a man on the moon in 1962 by the end of the 60s. I will tell you that when John Kennedy said that, President Kennedy said that, I don't think he understood all the science how that was going to be pulled off. And yet, by saying it, and by believing it, and by leading a nation to believe it, the bottom line is Neil Armstrong stepped on the moon in 1969. I'm going to tell you point blank, we have the tools to end the AIDS epidemic, right? And now I'm going to tell you, and again, may not make all of you comfortable, and I understand your skepticism, we have the leadership now within the Department of Health and Services, Secretary Asa, the President of the United States, to have an initiative to work with you to get this done. And I understand the skepticism, but you can either work with us to help bring this dream into reality, the same way that John Kennedy got a man on the moon, and that's what I'm asking you to try to do.
Keep the Affordable Care Act in place.
So finally, I just want to end with the fact that I think we have the tools to end the AIDS epidemic. And the real goal here is to see if we can come together, again, in a program that we anticipate will be not top-down driven. It will be developed by each jurisdiction, by the community, as I said, for the community and in the community. Those communities need to understand what are the key gaps to make this thing happen. I do ask your help. I do ask your help with the young men and women who do get infected in the first year or two, to have them have the courage.
We're not infected people.
I do ask your help with persons living with HIV infection. For them to engage with us to help accomplish that.
We have a retrovirus where we have U equals U. We will not take or affect anyone.
It's going to take, obviously, time for us.
Please don't patronize us. We are doctors, lawyers, professors.
Patronize anybody. I just would like to say that I have had the opportunity to spend many years, the privilege to provide medical care to many men and women living with HIV infection. Many friends. I know I'm trying. I'm trying. I appreciate it. I'm trying, and I think I'll keep working at it.
You'll get it.
I keep working at it. Hopefully, as my friend Jesse will hopefully attest, my heart is with the men and women living with HIV, and I hope to work with you today. I want to thank people for giving me my lesson plan for how we study this very carefully. You've given me this about 25 years ago.
Thank you.
Here's the pack. Why are you eating the pack?
So Dr. Redfield has
What about crack? What about crack? What about crack? What about crack?
So let's ask her about crack. So let's ask and from tape. Received all of your questions, and Dr. Redfield has asked if he can answer them. And question number 1. The Washington Post reported on Wednesday that the CDC holds a patent on pre-exposure prophylaxis. Will the CDC, first of all, before I answer this question, our partner in asking questions today, Oriah Lester, the new Oriah, will you join me in asking your questions? Question: will the CDC request a review of the CDC's patents and Gilead's production of Truvada as PrEP in order to obtain possible royalties from Gilead as resources to fund the HIV prevention portfolio and PrEP access?
Well, I know you're not going to like my answer, but... I can't comment on any possible negotiations that are going on with any entity. So
Nothing for us without us! 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 We funded it! You can get us a seat at the table! I'm sorry, we've watched our friends get infected because they can't afford a drug that costs $6 to produce and they charge $2,000 to it. You enforce the patents against Gilead, against generic manufacturers overseas. Why don't we see anything from it over here?
We paid for it! You own it! Enforce it!
Why can't we have a seat at the table? You take our money, but you don't let us have a voice. You want us to get scraps at the table.
Nothing for us without us.
What I can say is, as you saw that when we talked about the key elements, protection, providing comprehensive prevention to all people at risk for HIV infection is fundamental to this initiative.
It's been 3 years, 120,000 new infections, and you do nothing.
And that is our commitment, that we will, in this initiative, work to make sure all people get access to comprehensive prevention, including PrEP.
People can't afford it because you don't enforce it!
Dr. Redfield, what steps will the CDC take to increase affordability and accessibility of PrEP, particularly considering the federal government's significant investment?
Again, I want to just highlight that the really important component of this initiative is the comprehensive access to prevention for all people at risk. This initiative is designed to make sure all people get access to PrEP and comprehensive prevention services.
So why is there
independent
billions
of
of
their
dollars on
ability
the
to pay.
table?
The programs need more money! Give them more money!
Our under-resourced communities can't get it. Our poor communities can't get it. Our drug users can't get it. You're going to tell us unicorns are rainbows and expect us to say goodbye out of you.
The CDC has the legal
Why
right
did
to
you
get
tell us
money!
about
The initiative that we put forth, that
it? It's $250 million.
that we're talking with you now, is that the initiative has as one of its fundamental pillars that all people will get access to comprehensive
7 years later.
7 years later!
So we have additional questions that have come from all of you. I know you want to hear them.
No, we have recommendations.
One of those recommendations is, how will, given the many populations that we know are at risk and living with HIV, including men who have sex with men, sex workers, the transgender population, Black and Latinx individuals, what is your plan for addressing discrimination and stigma faced by those populations, including under the guise of religion? That stands to
You know, I think you know that fundamental to me is that all people have inherent dignity and should have the right to feel good about who they are. I've said this before, and I'll just say it again. We have a lot of work to do. I understand. I'm learning myself, as I've been told many times today. But stigma is the enemy of public health in all forms. In all forms.
No privilege.
In all forms. And whether it occurs in the form of a religious community or whether it occurs in the form of other aspects, I think it's really a lot of work we have to do is to remove stigma. I've seen more so the hurtful stigma that I've seen in particularly in the last decade in transgender persons. I continue to see the stigma, obviously, in young men who are sex with men. But all I can do is say the only way we're going to get rid of stigma together is to continue to do what you did to me today. When somebody uses terms that they find to be stigmatizing, to try to help bring that to their attention so that we can create a society that becomes less and less stigmatizing each day.
Well, in light of all the voices here and the community members that are here, how does the CDC plan to end the epidemic? How will you include and enlist the community people, these individuals, as experts?
We need a meeting with you. We need a meeting. We have to.
One of the ways that we began this conversation with my friend Jesse was really to begin to come and have the opportunity to talk to you today. One of the other ways I want to tell you is each of the jurisdictions that are going to be asked to put together these plans on how they intend to use the resources to reduce new HIV. And they need to bring the community in as central partners. As I said, Admiral Gerard and I say that this is a plan that has to be made by the community, for the community, and in the community. So I would challenge all of you in the jurisdictions that are going to be involved to be very involved. And again, we will be giving our guidance that we expect this to be a plan developed by the community, for the community, and to the community.
And will the CDC and administration commit to creating oversight committees, including community members, including people living with HIV, trans individuals, LGBT individuals?
Yeah, the current plan is to work in partnership between CDC and HRSA and to learn from the effectiveness of the Ryan White program and develop very similar community-specific groups to help guide these plans from the community. Again, this plan is in its infancy. We're hoping that you all will fully engage in it so that it will be not our plan, that it will be your plan as well.
In your backyard, in the Minnesota, you have a community called
Take down the surveillance. It's being used.
Well, on that topic on surveillance, what protections are being put in place to ensure that HIV molecular surveillance data isn't used to prosecute people?
The current is to identify areas of clusters. It's not to be name linked.
Dr. Redfield. Research has shown that housing, food, and nutrition, as well as transportation, are critical to achieving improved health outcomes for people. What funding and policy development will be included in the administration's plan for these services that are needed to assure that we achieve our goals.
I think that we've all come to realize that the social determinants of health have enormous impact, and they really are part of health. Again, each of the jurisdictions are going to need to decide where do they think these resources should go.
We know what the resources
Well, each community will decide, as we see with Ryan White, where you can have housing, where you can have different
He certainly did, and thank you for taking the risk to be here and to hear from us. Dr. Redfield, you will hear more from us. You will hear more from us because this is just the beginning. And now you know how we feel and what we need. Thank you for being with us.
My final comment, I just want to thank you for the opportunity. I want to echo what Jesse said and let the dialogue continue. I mean very certainly what I said when I first talked to him, and I said it again today, that the success or failure of this initiative is going to rest with the full engagement of the community.
You won't answer our question.
And so that's how I would ask you to continue to move that dialogue.
Dr. Redfield, these are all lives. Thank you for being here. We will have more dialogue with Dr. Redfield, with all those agencies. I hope you know this is just the beginning. Thank you. Thank you, sir. And now we want to hear from you. We have a panel of experts who are going to now come to discuss what we've heard. So, Carl?
Thank you, Dr. Redfield, for making the time to come and speak. I know the community has a lot of questions. We're going to leave the question. Can I get everyone's attention? All right, I'm not a teacher. I know people do that. Clap one time if you hear me. Clap 2 times if you hear me. All right, thank you very much. We have a panel coming up, but I was going to say, we're going to leave the community